Usually when we talk about a medical diagnosis, there's this expectation of just absolute undeniable precision.
Right, like it's engineering or something.
Exactly. Like if you break your arm, the x-ray shows that jagged white line in the bone, and the doctor just points at the film and says, there it is.
It's comforting, I think, because it's so binary, like
Yeah.
broken or not broken.
Yeah.
As clinicians, and obviously as patients too, we just naturally prefer things to be highly visible and easily categorized.
But then you step into the world of pediatric ear, nose, and throat radiology, and suddenly that x-ray machine is looking at a landscape that is just constantly shape-shifting.
Oh, absolutely.
We're looking at these tiny biological structures that aren't even fully formed yet. It is vastly less like reading a static map and much more like trying to map a bustling city while it is actively being built.
Which, fundamentally alters the entire rulebook of imaging.
Right.
You cannot just take an adult radiology protocol, scale down the radiation dose, and apply it to a 6-month-old.
Because they're not just tiny adults.
Exactly. The infant's physical anatomy actively fights against the imaging technology itself.
Okay, let's unpack this, because understanding why a baby's anatomy is so hard to capture is really the key to everything we are exploring today. Welcome to the deep dive, everyone.
It's glad to be here.
Today, we're looking at how doctors see the invisible inside children. Whether you are a medical student prepping for rounds, a young professional in the field, or just an insanely curious learner, we are taking an intensive journey into how advanced imaging is used to solve pediatric medical mysteries.
And it really is a mystery sometimes.
It totally is. We are pulling these clinical insights from the comprehensive textbook Pediatric ENT Radiology, edited by S.J. King and A.E. Boothroyd.
And to understand the imaging hurdles they outline in the text, we really have to look at the physical composition of a child.
Right, the anatomy.
Yeah. First, you are dealing with unossified cartilage. In an adult, the skeleton is mostly hardened, calcified bone, which blocks x-rays and shows up beautifully on scans.
But
in a baby, huge portions of the facial and laryngeal structures are still just soft cartilage.
Wow, okay.
And cartilage is radiolucent on traditional plain films. The x-ray beams just pass right through it.
Meaning it essentially doesn't show up at all?
Exactly. It's just a ghostly void on the screen.
That's wild. So you're basically flying blind.
In a way, yeah. And the second major hurdle is the lack of fat planes.
Fat planes?
Yeah. So in adult anatomy, fat acts as this brilliant natural contrast agent. It sits between muscles and blood vessels, visually separating them on a scan so you can easily distinguish one structure from another.
Oh, so it outlines things.
Right. But in infants, everything is packed incredibly tightly together with very little fat. So the tissues often just blend into one uniform gray blob on traditional imaging.
Okay, so we've got invisible cartilage and gray blobs.
Yep. And the third hurdle is simply the patient themselves.
Oh, right, because they're kids.
Right. An adult will hold their breath and lie perfectly still inside an MRI tube for 45 minutes.
Good luck getting a toddler to do that.
Try telling a terrified 2-year-old to hold perfectly still. It absolutely will not happen.
So what does a doctor even do?
Well, the clinical reality is this constant high-stakes negotiation. You desperately need high-resolution images to guide a potentially life-altering surgery, but you have to balance that against the long-term risks.
Right, like giving a growing child ionizing radiation from a CT scan.
Exactly. Or, alternatively, subjecting them to the inherent risks of general anesthesia or deep sedation, which frankly is usually the only way to get an infant through a lengthy MRI.
Man, so we have this incredibly delicate balancing act. Let's see how it plays out in practice by starting with our first stop on this anatomical journey. The structures governing hearing.
A great place to start.
A common yet devastating pediatric issue is congenital deafness. The source text points out a massive historical shift here.
Well, massive.
It wasn't that long ago that a child born completely deaf was just labeled as having idiopathic hearing loss, meaning the doctors just threw their hands up and said, we don't know why.
But today, otolaryngologists and pediatric audiological physicians utilize highly targeted protocols with high-resolution CT or MRI.
And what are they finding?
We now realize that a huge portion of these so-called idiopathic cases are entirely structural.
Like physical defects.
Yeah, it's an architectural failure of the inner ear.
And one of those architectural failures the textbook highlights is Mondini's dysplasia.
What's fascinating here is how the physical space dictates the biological function.
Okay, break that down for me.
So in a normal inner ear, the cochlea, which is the snail shell-shaped organ that translates sound waves into nerve impulses, it has 2.5 full turns.
Right, like a spiral.
Exactly. But in Mondini's dysplasia, the cochlea only develops 1.5 turns.
Wait, but how does missing a single turn actually stop a child from hearing?
Because the cochlea operates on physical real estate.
Real estate?
Yeah, different frequencies of sound stimulate different microscopic hair cells along the spiral of the cochlea. High pitches trigger cells at the base, and low pitches trigger cells at the very apex of the spiral.
Oh, I see where this is going.
Right, if that final turn never develops, the physical real estate required to process those specific low frequencies literally doesn't exist.
Wow.
The sound waves enter the fluid of the ear, but there is no cellular machinery there to translate the wave into an electrical signal for the brain.
That is incredible. The hardware just wasn't fully manufactured.
That's a great way to put it.
And there is another structural marker that stood out in the text, the abnormally dilated vestibular aqueduct.
Right.
The vestibular aqueduct is this tiny bony canal that houses a fluid duct, and if it's too wide, it's a huge red flag.
It is the crucial marker for Pendred syndrome, which is a genetic disorder that causes progressive hearing loss.
Progressive meaning it gets worse over time.
Yes. If the aqueduct is abnormally wide, the fluid pressure regulation within the inner ear is compromised.
And seeing that on a scan changes things.
Completely. Identifying this specific structural flaw early profoundly alters the child's entire life trajectory. It changes their medical management, triggers earlier audiological interventions, and, alters their educational path before they fall behind.
Okay, so for diagnosing congenital deafness, advanced imaging is a total game changer.
Absolutely.
But what about the other end of the spectrum? Acute otitis media.
The classic ear infection.
Right, the everyday childhood ear infection. The screaming toddler clutching their ear at 2 in the morning.
We've all seen it.
If you're listening to this and wondering, hey, if imaging is so great, why don't we just scan every earache to be safe? Well, this brings up what I call the imaging threshold.
Which is so important to grasp.
Yeah.
Doing a CT scan for a routine ear infection is immense clinical overkill.
Yeah.
And frankly, dangerous due to the unnecessary radiation.
Yeah.
The vast majority of acute otitis media cases are diagnosed simply by a doctor looking into the ear with an otoscope. They either resolve on their own or with basic antibiotics. No advanced imaging required.
I like to think of it like you don't use the Hubble Space Telescope to find your lost car keys.
Precisely. You only cross that imaging threshold when you suspect severe complications.
Like what?
If the child continues to spike a high fever after a week of antibiotics, or if they present with extreme tenderness in the bone directly behind the ear.
The mastoid bone.
Right. Or if they display neurological symptoms like lethargy. That is when you must look deeper. The infection is no longer just in the ear, it is breaking out.
It's actively invading the surrounding territory.
Exactly.
We are talking about mastoiditis, where the pus and infection fill the honeycomb-like mastoid air cells in the skull behind the ear, or an epidural abscess where the infection pushes against the brain lining.
And when you cross that threshold, you must choose your imaging modality based purely on physics.
Okay, physics.
Yeah, for acute bone complications, computed tomography, or CT, is the absolute first-line investigation.
Wait, let me push back on that for a second. We just established that we want to avoid giving growing kids ionizing radiation whenever humanly possible.
We do.
An MRI uses powerful magnets, zero radiation, so why not use an MRI to check on this aggressive ear infection?
It's a fair question. The reason is that an MRI is effectively blind to the fine architectural details of bone.
Really? Blind to it.
Pretty much. MRI generates images by manipulating the protons in water and fat molecules.
Okay.
Bone has very little water. So on an MRI, bone largely appears as a dark void.
I see.
But a high-resolution, thin-section CT scan using a specialized bone algorithm uses X-rays to measure tissue density.
Which makes bone light up like a Christmas tree.
Exactly. The CT allows the radiologist to see the microscopic trabeculae, the tiny interlocking calcium struts that form the honeycomb structure inside the mastoid bone.
Wow.
It allows us to see the delicate microscopic middle ear ossicles,
Wow.
the malleus and ecrussus and stapes. With the CT, you can physically see if the infection is eroding and destroying those tiny calcium struts.
MRI just can't do that.
And the MRI cannot show you that bone destruction.
So it's not about one being better than the other. It's about the physical properties of the scan. You use the CT to verify if the bone is actively melting away from the infection.
Exactly right.
And if you suspect the infection has eaten entirely through the bone and entered the cranial cavity, threatening the brain or the major veins, that is when you bring in the MRI, because MRI excels at showing fluid, pus, and soft tissue inflammation.
They are entirely complementary. And this complementary approach also applies to the rare instances of pediatric tumors in the temporal bone.
Right.
You need the CT to map out the bony destruction caused by a malignant tumor, like a rhabdomyosarcoma, and you need the MRI to map how far that tumor has invaded into the surrounding brain tissue.
Fascinating. So we've seen what happens when the structures governing hearing fail and how doctors navigate that space.
Yeah.
But the stakes get even higher and much more immediate when we look at the structures governing a baby's very first breath.
The airway.
Yes. Let's move centrally from the ear into the nasal passages and the nasopharynx. The condition here is choanal atresia.
Choanal atresia is a congenital condition where the posterior nasal airway, the physical tunnel connecting the back of the nose to the throat, is completely blocked, either by a wall of bone or a thick membrane.
And the presentation of this is terrifying.
Oh, it is.
Because neonates, newborn babies, are obligate nasal breathers. They do not intuitively know how to breathe through their mouths.
Right. They're biologically wired to breathe through their noses so they can suckle and breathe at the exact same time.
So if a baby is born with bilateral choanal atresia, meaning both the left and right nasal passages are blocked, they present with profound respiratory distress the second they are born.
They are trying to inhale, and literally nothing is happening.
But there's a diagnostic clue, right?
There is. The diagnostic clue for the physician is that the moment the baby gets agitated and starts crying, they suddenly turn pink and oxygenate.
Because the physical act of crying forces them to open their mouths, temporarily bypassing the nasal blockage.
It's an alarming cycle. But from a diagnostic perspective, it's highly significant. Bilateral choanal atresia is frequently associated with broader genetic syndromes.
Yeah, the textbook notes it's heavily linked to the charge association.
Exactly.
Which, for our listeners, stands for coloboma of the eye, heart defects, atresia of the choanae, retarded growth, genital hypoplasia, and ear anomalies.
Right.
But wait, why would a nasal blockage be linked to something like a coloboma, which is basically a missing piece of tissue, like a keyhole defect, in the iris of the eye? What connects the nose to the eye and the heart?
It all comes down to embryology. During fetal development, all of these seemingly unrelated tissues are migrating and forming at the exact same time, usually around the 5th to 7th week of gestation.
Oh, okay.
If an environmental or genetic insult occurs during that highly specific developmental window, it damages every structure that happens to be under construction at that exact moment.
So the tissues are embryologically linked by time.
Exactly.
Here's where it gets really interesting from an imaging standpoint. You have a newborn infant in severe respiratory distress unless they are actively crying.
Right.
The surgeon urgently needs a high-resolution CT scan to see exactly how thick the bony blockage is before they operate. But as we established earlier, you cannot give sedatives to an infant who is already struggling to breathe. It's too dangerous.
Way too dangerous.
So how on earth do you safely run a CT scan on a squirming, distressed, wide-awake baby?
It requires intense clinical coordination. The text details how these scans are performed incredibly quickly, but critically, they are done with oral airway tubes already securely taped into the infant's mouth.
A physical plastic tube just holding the mouth open.
Yes. It keeps the mouth open and the airway entirely secure.
Okay.
Because the baby can suddenly breathe comfortably through the tube, they calm down and stop thrashing.
Wow, that makes sense.
The stillness allows the scanner to capture the incredibly thin, sub-millimeter slices needed to map the microscopic nasal obstruction.
It's a brilliantly simple physical workaround to a high-tech problem.
It really is.
Now, as kids get older, the nasal issues usually shift from congenital blockages to inflammatory ones, things like chronic rhinosinusitis.
Right.
For children who don't respond to maximum medical therapy, antibiotics, nasal sprays, they might eventually need FESS or functional endoscopic sinus surgery. And the radiologist is essentially creating the surgical map.
And the technique here is highly specific. Low-dose coronal CT scans. Coronal slices mean the scanner is imaging the face from front to back.
Why not just use standard top-down cross-sections?
Because the coronal view precisely orients the anatomy exactly as the ENT surgeon will see it when they insert their endoscope straight into the child's nose.
Oh, so it's a direct preview for the surgeon.
Exactly. It highlights the delicate drainage pathways and flags any hidden anatomical variants that could cause the surgeon to accidentally breach the surrounding structures.
And those coronal views are absolute lifesavers when a basic sinus infection goes terribly wrong. The text mentions orbital cellulitis. The sinuses sit right next to the eyes, separated by a bone called the lamina papyracea, which is Latin for paper-like layer.
And it is incredibly thin.
If a sinus infection melts through that paper-thin bone, it enters the eye socket. And the coronal CT is crucial to spot a superior-steel abscess.
That is a highly pressurized pocket of pus forming directly against the roof or floor of the eye socket.
Which sounds awful.
It is an absolute surgical emergency because the building pressure can stretch the optic nerve and cause permanent blindness in a matter of hours.
Just terrifying. Moving slightly further back into the nasopharynx, the space right behind the nasal cavity, the textbook highlights how simply knowing the age of the patient changes the entire radiological strategy for tumors.
Because age alters the differential diagnosis.
How so?
Well, if you image a bulky mass in the nasopharynx of a very young child, say a 5-year-old, statistical probability points to a rhabdomyosarcoma.
Which is a highly aggressive cancer of the soft tissue, sometimes presenting as sarcoma botryoids, where the tumor cluster physically protrudes out of the child's nostril.
Yes. Conversely, if you are imaging a teenager, maybe 15 years old, with a nasopharyngeal mass, the suspicion shifts entirely.
What are we looking for then?
At that age, you are highly concerned about nasopharyngeal carcinoma. And the imaging protocol changes because nasopharyngeal carcinoma almost always presents alongside massive bilateral enlarged lymph nodes in the neck.
Oh, so you have to look lower down.
Exactly. You have to expand the imaging field to capture those nodes for staging.
We've mapped the airway from the nose down through the back of the throat, but as we follow that path down into the neck, the physical location of a bump or mass suddenly becomes a map of the child's fetal past.
It's fascinating.
The text points out that evaluating a mass in a child's neck is almost entirely based on understanding embryology.
Because when a fetus is developing, structures don't just appear where they belong. They form higher up and physically migrate down the neck to their final destinations.
I try to picture this like an intricate embryonic zipper.
I like that.
As the fetus develops, tissues from the left and right sides grow toward the middle and zip together. Sometimes the tissue doesn't fuse perfectly. A tiny pocket of fluid gets trapped in the folds.
Like a little bubble caught in the zipper.
Exactly. And that trapped bubble eventually becomes a fluid-filled cyst.
That's a highly accurate way to visualize it. And because we know exactly where the zippers are, the golden rule of congenital neck masses is locational.
Right.
Lateral lesions, those on the sides of the neck, originate from paired embryonic structures that were fusing. The most common is a branchial cleft cyst, which you will almost always find sitting right along the front edge of the sternomastoid muscle.
Because that is exactly where the fetal branchial arches were fusing. It's the only place that specific bubble could get caught.
Exactly. But if you find a mass sitting dead center in the exact midline of the neck, it likely originated from a central structure that was descending.
Like a thyroglossal duct cyst.
Yes, which forms along the exact vertical track the thyroid gland takes when migrating from the base of the tongue down to the lower neck.
Okay, let me pause you there because this feels like a massive logical trap.
How do you mean?
If I'm a young, confident surgical resident and I see a solitary cyst sitting dead center on the base of a child's tongue,
Yeah.
my instinct is to just cut it out. It's an unwanted bubble in the zipper. Get rid of it, right?
If we connect this to the bigger picture, acting on that instinct without proper imaging is how you induce a catastrophic, lifelong medical error.
Why?
Because sometimes the thyroid gland fails to migrate downward. It just stops halfway and sits at the base of the tongue. It presents as a firm midline mass called a lingual thyroid.
Oh, wow. So that cyst isn't an unwanted bubble. It's the child's entire thyroid gland.
Precisely. It is their entire metabolic engine. If a surgeon just cuts it out, assuming it's a benign cyst, the child will have zero thyroid hormone production for the rest of their life.
That's a disaster.
This is why the text issues a critical mandate. Before excising any solid midline mass, you must perform scintigraphy.
Which is a nuclear medicine scan using a radioactive isotope.
Because the isotope will be absorbed by functioning thyroid tissue, wherever it is hiding.
Yes. You must functionally prove that a normal, backup thyroid gland actually exists lower down in the neck before you let a scalpel anywhere near that midline mass. You aren't just imaging the structure, you are imaging its biological function.
That is just incredible.
The imaging protects the patient from the intervention.
Exactly right.
Now, while we are focused on the neck, we have to talk about the larynx, the voice box, and the terrifying symptom of stridor.
Stridor is that high-pitched, harsh, noisy breathing caused by a physical obstruction in the airway.
It's a scary sound.
Evaluating a tiny pediatric airway used to rely heavily on direct endoscopy,
Yeah.
physically putting a rigid metal tube down a child's throat under anesthesia to look around.
Which is incredibly invasive.
Very.
But now, with high-speed sub-millimeter CT scanners, radiologists can perform virtual endoscopy.
Yeah, the computer software reconstructs the internal airway in 3 dimensions.
And the doctor can literally fly through the child's trachea on a monitor, spotting narrowed strictures or malformed cartilage rings without ever touching the patient.
But my absolute favorite technique mentioned in the entire text is the hidden gem for the infant larynx, laryngeal ultrasound.
Oh, yeah.
We talked earlier about how infant cartilage is practically invisible on an X-ray and hard to distinguish on an MRI because of the lack of fat. But ultrasound utilizes high-frequency sound waves.
Right.
And this is where the physical immaturity of the infant actually becomes an advantage.
Wait, really? How?
Because ultrasound waves travel beautifully through water-rich, soft tissues, but they hit calcified, dense bone and bounce back, completely blocking the view behind the bone.
But in an infant, the thyroid cartilage hasn't calcified into hard bone yet.
Exactly.
Yeah.
Because it is unossified cartilage, the sound waves pass straight through it as if it were a perfectly clear glass window. We call it an acoustic window.
That is so cool.
It avoids all ionizing radiation.
Mhm.
It requires zero sedation. The baby just sits comfortably on their parent's lap while the doctor places the probe on their neck.
Wow.
And it provides a brilliant, dynamic, real-time movie of the tiny vocal cords opening and closing. You can diagnose a paralyzed vocal cord non-invasively in minutes.
It is the absolute perfect tool, but only for that highly specific developmental window before the cartilage turns to bone.
Yep.
And really, that brings us full circle. So what does this all mean? When we dive into pediatric ENT radiology, we realize that taking the picture is the easy part.
Right.
The actual work is this constant high-stakes negotiation. You are trying to extract vital, life-saving structural data while simultaneously protecting a vulnerable developing child from radiation, from sedation, and from surgical errors.
It demands a rigorous understanding of the underlying biology. You have to know the embryology of the neck. You have to know how diseases present entirely differently at age 2 versus age 15.
Yeah.
And you have to master the physics of your tools, knowing exactly when the CT will illuminate the bone, when the MRI will map the soft tissue, and when the ultrasound will see perfectly through the unossified cartilage.
It's incredible.
Behind every single scan is a complex clinical puzzle. The objective is never simply to generate an image. The objective is to answer a highly targeted clinical question that will dictate how you treat the patient.
Which brings us to the end of our deep dive. And as promised, since our mission is educational, we want to leave you, the listener, with a final provocative thought, a clinical scenario to test exactly what we've unpacked today. Take this to heart in your studies, your exams, or your practice.
Okay, here it is. Imagine you are the clinician on call in the emergency room. A 5-year-old child presents to you with a high fever. They have a severely erythematous eyelid, meaning it is extremely red and inflamed and noticeable proptosis, where the eye itself is visibly bulging forward out of the socket.
Okay, scary presentation.
Very. The parents tell you the child has been battling a severe sinus infection for the past 2 weeks that hasn't responded to antibiotics. Based on the anatomical risks and the physics of the imaging modalities we discussed today, what specific scan and in what specific orientation would you request immediately?
And what exact vision-threatening complication are you urgently trying to rule out?
Good addition.
Think back to the lamina papyracea, that paper-thin bone separating the sinuses from the eye socket. Think about the physical orientation the surgeon needs to see the drainage pathways. We aren't going to give you the answer right here, but we've definitely given you all the pieces to solve it.
You've got this.
And if you need to rewind and listen again, well, that is exactly why we do these deep dives. Medical imaging isn't just about reading a static map. It's about understanding the mechanics of how to navigate the city while it's still being built. Thank you for exploring the invisible with us today.